Hi, my name is Katie Berry at the University of Virginia, and I'll be talking about comparison of urethral anatomy on contrast-enhanced ultrasonography versus voiding cystourethrogram. How reliable is contrast ultrasound? For some background, contrast-enhanced voiding ultrasonography, also known as CVIS, uses echogenic contrast composed of gas-encapsulated microbubbles, which can be seen on ultrasonography. So unlike voiding cystourethrogram, VCUG, you do not need to use radiation. It can be utilized for evaluation of vesico-urethral reflux. It can also be used for CVIS urodynamics, as we have studied at our institution, and it can be used for urethral assessment as well. So our question is, how reliable is contrast ultrasound for urethral anatomy assessment? In order to start answering this question, we looked at our cohort of children who had undergone both CVIS and VCUG studies that included full imaging of the urethra. These imaging studies had to have been done within 24 months of each other, and the patient could not have had any interval urethral surgeries. Ultimately, we had 39 patients who met this criteria. 61.5% of them had undergone CVIS for vesico-urethral reflux concerns versus 38.5% had undergone for neurogenic concerns via CVIS urodynamics. Screen captures were obtained of the urethral portion of all of these imaging studies. These were then de-identified and randomized so that the images were no longer paired for the same patient. Videos of the urethral portion were provided to our two pediatric urologists at UVA. These were then read as either normal, abnormal with dilated proximal urethra, either from detrusor sphincter dyssynergia or spinning top, or there was a section for other for additional comments. This is an example of CVIS urodynamics as performed at our institution. We have our pediatric urologist in the room interpreting results in real time. We have our patient care tech who is helping to assess whether or not our patient is voiding, our ultrasonography tech, and then both parents are in the room throughout the entire study, helping to keep the patient watching their iPad and keeping them comfortable throughout the exam. This is an example of a 5-year-old girl with lumbar myelomeningocele who had undergone CVIS urodynamics due to a change in her bladder and bowel function. Here you can see the real-time voiding phase of the CVIS urodynamics study. Here are a few examples of what we compared. This first set of images are from a female patient with myelomeningocele. This example shows the studies being read as completely concordant, meaning both readers interpreted the VCUG as DSD, and both interpreted the CVIS as DSD. In contrast, these images from a female patient with myelomeningocele show when both urologists read the VCUG the same as DSD. However, their interpretation of the CVIS differed, with one reader interpreting as DSD and the other as normal. Additionally, this is an example from a female patient with bilateral vesico-urethral reflux, in which the reads for the VCUG between urologists agreed, and the reads of CVIS agreed. However, the two studies were interpreted differently. Both readers interpreted VCUG as consistent with spinning top with proximal urethral dilation, versus CVIS appeared normal. Putting it all together, these are our results. 54% of our patients were deemed to have abnormal urethral pathology in at least one of their studies as deemed by at least one provider. Pediatric urologist number 1, when comparing their reads for CVIS and VCUG studies for the same patient, were in agreement 72% of the time, versus pediatric urologist number 2 was in agreement 59% of the time for the same patient between the two studies. Comparing the two urologists in terms of inter-rater reliability, having the same read for each CVIS or each VCUG, 77% of the time they agreed on the read for the CVIS, versus an increased 85% of the time they agreed on the reads for the VCUG study. In conclusion, this data suggests that there may be better inter-rater reliability for VCUG compared to CVIS. However, ultimately, interpretation between the two studies was incongruent in 30 to 40% of cases. Some of these differences may be due to inconsistency in comparing these studies versus actual pathology changes over the time between the studies, which was a maximum of 2 years. At the end of the day, this is a very small preliminary study. We only had 39 patients, and we had 2 urologists doing the assessment. Moving forward, we always want to include more patients within our cohort, but also include additional readers, including pediatric radiologists. This may help decrease some confounding factors of the differences in how the 2 urologists may read the study versus the difference in exposure or experience in reading CVIS versus VCUG throughout their careers. We are hopeful to get a better understanding of CVIS reliability for urethral imaging moving forward with these studies. Thank you.